ACL injuries occur during a pivot shift event, which can be a non-contact or contact. The pivot shift event, the thigh bone and the leg bone rotate in different directions, tearing the ACL, and oftentimes on MRI we see a bone bruise. There's a spectrum of injury that presents with partial tears with low contact or low energy mechanisms, isolated complete tears with more energy, and then additional concomitant injuries or additional injuries with more energy. So we see in instances of one meniscus tear, two meniscus tears, or two meniscus tears with cartilage injury, all based upon the amount of energy at the time of the pivot shift event. The story that patients often present with include a twisting injury. Oftentimes a pop is felt and there's a fall to the ground. Athletes often are unable to continue playing that day and the knee swells. They subsequently have feelings of instability and that the knee gives out on them. With diagnosis, we start always with the story, and that is 80% of what is included in the diagnosis. This patient's a 17-year-old high school lacrosse athlete. Physical exam is 15%, and he had a Lockman that was grade 2 out of 3 with a soft endpoint and a pivot grade of 1. X-rays help us because we look at mechanical axis to think of risk factors for injury as well as concomitant injury and subsequent concerns. Also, we look at posterior tibial slope. It is a risk factor over 12 degrees of ACL injury. MRI fills in the details and helps us to confirm the diagnosis. This patient had a complete ACL tear, a deep MCL tear, and possible meniscus tears. When we first view inside the knee, we see in this case that 5% of the native ACL is intact, 95% is flipped forward, and we see an empty notch sign, as you see here, indicative of the injury. As we investigate the injury further with the scope, we'll look posteriorly through the injury and see where it is specifically pulled off the femur here in this location. Our first order of business is to remove the old torn ACL stump, as you see us performing with this shaver. In this case, 95% has flipped forward and is blocking his full extension, which is not uncommon in this injury pattern. After we remove the stump, we often perform a notchplasty, which allows for more room of our reconstruction, so there's not further impingement of the graft upon the notch, nor risk for further injury. We evaluate the lateral meniscus because posterior lateral meniscus tears are common in this injury pattern. This case had a partial longitudinal tear of the posterior horn of the meniscus. We do our best to always repair meniscuses because it's important for long-term joint preservation. Here you can see we have a nice vertical mattress suture. We then evaluate the medial meniscus, starting from the anterior medial viewing portal with palpation. We look at the meniscus and evaluate it not only from the front, but we also drive posteriorly. With driving posteriorly, we look for a ramp lesion, which when present right here and represent further up the injury pattern in terms of energy. We then pull our grafts through a tibial tunnel and into a femoral socket, securing them on the femur with a cortical button and on the tibia with an interference screw. After we get the graft into place, we check its tension. We want to make sure that we have full extension with no further graft impingement on the intercondylar notch, confirming that the tension is appropriate and that we have full extension. Our rehabilitation typically takes 9 months, and this is guided upon studies of re-injury rates and outcomes. Our phase 1, we protect our lateral meniscus repair. For this patient, we kept him toe-touch weight bearing for 2 weeks and then a 1-week crutch weaning protocol. Our phase 2 is regaining full motion after that protection phase and normal life function. We then rehabilitate strength and neuromuscular function, focusing on strength and proprioception until really 7.5 months while the graft goes through ligamentization and matures. Phase 4 is agility and sport-specific training. It is from 7.5 months to 9 months. And then phase 5 is a return to sport. See our blog if you're interested more in why it tends to take us 9 months or doesn't take us 9 months, but 9 months is appropriate to allow for the ligamentization and a full, safe return to sport.